All right, ladies and gentlemen, welcome to High Bar Sports Physical Therapy Podcast. Today, our sports therapy experts, we're bringing them on in a minute, will give you an in-depth look into the world of concussion management in athletes. This is a topic that's come up time and time again. And the goal of today's conversation and episode is to help you, the audience, feel a little more confident and competent in treating those patients. All right, let's bring in the experts. First up, a doctor of physical therapy who specializes in orthopedics, sports-related injuries in areas like hockey, football, lacrosse, baseball, and rugby at High Bar Health. Welcome, Reid. Reid, welcome to the program.
Hi, everybody.
All right, let's bring in our second expert. We bring our own crowd noise, which is always good. You got to bring your own crowd noise. It's what hypes us up. Our batting second, a doctor of physical therapy, also specializes in manual therapy, acute and chronic spine pain, headaches, sports injuries, TMJ, and vertigo. Let's welcome in Dave. Dave, welcome to the show.
Hello, Jimmy. Hello, Reid. Thanks for having me.
Thanks for being here and allowing me to be your producer. The show, I sort of tried to set the stage there. At High Bar Health, you guys have something called special interest groups, essentially groups that meet independently within the practice. And the goal there is to share knowledge, to gain insight, to collaborate. And we thought instead of closing that off, why not open that up? And that's why we're doing a live stream today. So I will tell the audience, either listening live or recorded, if you'd like to ask a question on any of the social platforms this is broadcast on, you can do it in the comments below. Live, we'll try to answer it right on the spot. Recorded, I'll just send Dave and Reid the questions and they can answer them afterwards. So today's topic, Reid, you sort of picked this one. This was on your docket, concussion management in athletes. You know, why'd you pick this one? Why was this important enough to discuss and discuss again?
Yeah, I mean, it's a hot topic right now in professional sports, as much as anything else. Obviously, the movie Concussion came out a few years ago. It's been a big topic for parents trying to decide if they're going to let their kids play contact sports like football, for example. I think the important piece is to understand concussions, understand they can happen in every sport, and understand then how to manage it if it does happen.
All right, well done. It comes up a lot, right? And we always love to throw around this, well, it depends, because then you're going to need to go a little deeper, whether you're talking to someone on the sidelines of a field. So this is the area where we get to go a little deeper and talk about it depends. So Reid, I'm going to sort of step out since I did the intro and stuff. I'm going to step out like the experts. I'll be lurking in the background. I'll be manning the questions, and I'll just be just manning the live stream. So gentlemen, the stage is yours.
Awesome. I think when it comes to concussions, the most important thing to start with is understanding them, right? A concussion is not an injury that you can find on an X-ray, an MRI. It is a mild traumatic brain injury that is non-diagnosable with imaging. So it's hard to sometimes pick out when somebody has a concussion. So being able to identify those injuries becomes super important. They don't have to be contact in all cases. Of course, contact injuries, contact sports is much more likely to have a concussion, but you can have a non-contact injury just from a whiplash type movement. They call it a coup, counter coup contact of the inner part of the brain and the inner part of the skull. And it gives you this mild traumatic brain injury. The big thing is to look for symptoms. Symptoms are how we come to this diagnosis. The dizziness, headaches, light sensitivity, drowsiness, nausea, confusion. And you don't have to have all, you don't have to have more than a few to really be able to diagnose you with that concussion. The big thing they've been pushing in the NFL realm has been identification, which is really interesting. They now have independent people on the sideline watching hits happen, watching players get up to identify, is that a risk for a concussion type contact or a concussion type injury, which is a great thing you're starting to see in those higher tiers, but you don't see that in the high school sports. And that's where it gets a little bit interesting. So any thoughts there, Dave, from high school age kid, how we're managing it from that level? Or
For sure, Reid. I think it's super important to start with identifying it and being more aware of it. And I mean, you with your hockey background see this quite a lot. And I think we see it in other aspects of PT as well, right? Oftentimes we're the first to let our patients know that we see these types of injuries. We understand the prevalence when they're the types of things that in the past, I know couple of pretty significant concussions back in high school playing soccer. And I don't know if you can rub dirt on a concussion, but pretty much that was my approach back then, and headache for a couple of weeks. And my parents didn't know, my coaches didn't know, and you jumped right back into it, right? And so there's so much more identification for it now. And knowing your background, let me push it back on you. What are you seeing, right? There's obviously been a little more awareness in recent years. What are the most common sports and causes you saw? And maybe this is a little bit of a quiz too. I recently, saw a list, and there were a couple of things that I didn't think would be on there too. Let me see what you got, and I'll pull out the other one that I wasn't going to think of.
Obviously you see a lot in your contact sports, like your footballs. You see a lot in rugby. It's actually the highest incidence of concussion, according to a lot of the most recent research, is that rugby, a non-protective equipment game with full high contact, you have that. But you see it in every sport. There's actually been one particular way people have been getting injured and getting concussions more easily, and they found soccer headers to be a very common way for especially high school athletes to get concussions, in part, not just because of the ball's coming all the way up the field and hitting you in the head at very high velocity, but people not knowing how to actually direct the ball, absorb the shock from it. So especially the high school age athletes, they're seeing a lot of concussions from soccer players on headers just because they don't know really how to play it properly. And that's been a big one. Is I've seen a big influx of patients coming in from soccer related injuries that it's not a sport you think of being that contact related injury, but just around here for some reason we've had a lot lately.
For sure. And yeah, like I said, I had two. Now one was more of a hazing related incident, but that's a story for another day over a pint with Jimmy maybe.
That's
but
different podcast.
The other was just an on-field injury. But in looking at the latest research, the ones that I wouldn't even have thought of, at least in the ED, cycling was a huge one, right? Like cycling injuries. Now, keep in mind, a lot of these would go unreported. So this is just people actually presenting to an ED before potentially seeing us, but cycling was on that list. Baseball and softball were even on that list.
Can I guess one? We weren't expecting this. And was cheerleading on that list?
I actually have the list in front of me.
Because what my study partner in PT school was a competitive cheerleader before going to PT school, and she threw that out, and I was like, that can't be. And it was I think per 1,000 it was high, like it was rather high.
Cheerleading is more of a contact sport than you realize. They come out tattered and bruised. All it takes is a small misstep, and you may not notice it from the eye, but they're hitting different body parts here and there. I mean, it is crazy.
Well, I feel like it's like cycling. It's like it doesn't occur until it does, and when it does, it's terribly severe, right? So when you're throwing the flyer, right, and I learned the terminology in PT school. It's not all I picked up, was anatomy and physiology. Flyer, that's the girl that's going up in the air. When there's a misstep there, it is very traumatic. I can't believe my first jump in for the podcast was to jump in with a cheerleading related concussion. But you're welcome, for everybody.
For sure, right? But if we're the experts on this, we're going to cast a wider net, right? So we've got the sports injuries as well. But once people are familiar with it, you're going to see, playground equipment was one of the top ones, and trampolines in kids. And we know that age 5 to 12 is sort of a less studied group that they're still looking into. But they're on the list, right? And once we've seen patients, hopefully they're thinking of us first and coming to us as the experts to rehab these the right way. One thing I was actually asked recently, Reid, was, and it's sort of something you started to touch on, is can you even prevent concussions, right? And I think people think of it as something you can do directly. Well, of course, the nature of the injury, it's very difficult, but there are preventative things. So I think of what you just said, heading a soccer ball in soccer, right? My son, I'm lucky enough to coach his team. I have a blast doing it. They're not allowed to head, and they won't be until they're 11, right? Different. When we started, we were just, running into the ball from the time we started playing. They are not allowed to head the ball. It will stop play until they're 11 years old. So that's sort of a rules-based approach to it, right? And obviously protective equipment is something they're looking at a little more. That's another piece that we can do to prevent them. But there's also something to be said for these neuromuscular training programs, right? We know concussion isn't simply a blow to the head, like you said. It can be non-contact. And I don't know, maybe you have a thought for that, Reid, because I think we'll get into, like, people think ACL prevention. Of course, I'm going to do some kind of neuromuscular strength training, but like, would most PTs have even been aware of it for concussion prevention?
Yeah, it's really interesting. I've actually seen there's been a trend in research going towards like cervical spine muscular training to prevent injury and prevent concussion. Essentially, the idea that if there is a cervical component to any sort of headache, dizziness, injury, like there is with concussion, that retraining the motor control, doing chin tucks or some sort of resisted neck strengthening has been beneficial in preventing that whiplash type concussion, which happens more frequently than you realize. So I'll be interested to see where that research goes. It's still kind of new, but they're trying to see if there's a correlation there from stronger and better neck control.
I agree. It's almost like the more research we have, the simpler things get, in that everything's related, right? Like a head injury is not just a head injury, an ACL injury is not just an ACL injury, right? There's a relationship between neuromotor control and even, the vestibulocular system, how it's working together. And you're going to probably see more of these types of injuries, whether it's an ACL or concussion, in somebody who maybe isn't developed, maybe somebody whose movement patterns aren't quite there, somebody who simply isn't strong, right? Or doesn't have the right movement patterns. So it's one of those that it's not always easy to connect those dots and therefore treat those things or explain it. And yet as PTs, we could be the first to identify, to recognize, and to even think of it a little bit from a preventative standpoint, at the very least preventing that next one, right?
Yeah, I mean, I know that's a big part of our practice act, is trying to move everything towards as much prevention of injury as possible, right?
Completely. And one last tidbit I got on that piece was, we've been seeing some things on, you mentioned imaging isn't going to be able to identify it. Well, there are some advanced imaging techniques they're looking at, and there's genetic testing, and there's like some way far out stuff. And yet from the latest guidelines, like, yeah, nice, cool, we'll see where it goes, but it's not enough to diagnose and guide our treatment yet. So just like a lot of other imaging techniques or fancy new gadgets, maybe there's promise for them down the road, but we need to, do it with, assess and treat with the skills we have. I don't know, maybe that's a good little segue into how we manage those, right?
Yeah, no question about it.
So
I think that's a great idea. Let's break down the process. I think it can be daunting. It's easier, especially thinking towards like the new grad brain. It's much easier to take the information, identify. I know what the signs and symptoms of a concussion are. I know, why we should identify it, what we should do, and we should do concussion testing. And then you say, all right, go and treat that patient. They go, well, how do I do that? And I think that's where the most important part of what we're going to talk about today is really where to get started, right? So I think the best way to start is know when to start. There's this thought behind concussion management is that you go into a dark room, you shut off the lights, you let somebody's brain recover, and you give them as much time as they need until their headache is magically gone. But according to all the research, that's the opposite of what you want to do. Other than the first 24 to 48 hours, you are actually doing a detriment to your system by taking away that stimuli. So as soon as you're out of that first 24 to 48 hours, 1 to 2 days of that kind of rest, absolute rest, you want to go more into a relative rest phase. That's where we can really come in and get started. What is relative rest? Relative rest is doing anything and everything you can do without directly getting your symptoms to come on. That is going for light walks, just gently challenging your aerobic system, doing gentle exercise for different body parts. I mean, you could just simply do some resistance training, very light for upper extremity, lower extremity. Again, anything just to challenge your body so that you're not in this phase of not able to take any sort of stimuli. So it's really interesting. People don't realize that right after that first 24 to 48 hours, honestly, coming to us would be the best case scenario to just accelerate that treatment. But But yeah, is that kind of what you've seen, Dave? Is that where management has gone from what you've seen?
I think so. I mean, even I can't believe I'm saying this, but like in my day when I first started, Reid, we didn't see those, those diagnoses come through as consistently, right? And I think part of that's on, obviously part of it's on the latest research and all providers being up to date on it, but a lot of it was PTs going to primary cares and messaging, the signs and symptoms and the latest evidence that, rest isn't going to cut it and they need to get into the clinic. Now, anecdotally, I think we've seen some strides there. And yet, in speaking to friends, family, fellow, parents of athletes, it's not always the case. I think it can often be, just look at the healthcare system as a whole. It can be, maybe relative rest works, but I'll get, the next appointment is 2 weeks from now, right? Mm-hmm. Now, the opposite end of that, I think parents, can be a little more, ambitious about their little athletes and want them to get back sooner, which is a good thing. In this case, you have to be your own best advocate. But is that how you've seen now? You're seeing more in those early phases getting to you quicker?
We're doing a better job. We're not doing a great job. So I think just in my time practicing, which has not been as long as yours, is not. In my time practicing, I'm seeing it improve. There are certain doctors who are really on the forefront of saying, no, get in immediately. But then there are some who are very much still behind on any of that research. And we don't see them until it really is becoming more of a post-concussion syndrome, when those symptoms are stuck and latent or not going away as expected, unfortunately, which we can definitely touch upon post-concussion syndrome and that idea later. But it's unfortunate, we're still kind of in that phase of hopefully that's starting to improve.
I always like to say save the questions to the end, but I like this one because it's in the moment. Jordan chiming in, and this is true. And I want to hear strategies from both of you. And Jordan says, trying to tell teens in high school to have relative rest with exams, early hours, after hours, sports, work, a life, friends, family is tough. What would the communication skill that you might employ to do that? How would you, I don't want to say you got to role play it with each other, but what would you do? What would you do in clinic?
Yeah, I'll go first in that, I think relative rest, does not mean shut it down. It means get back to ADLs early. We know that. And yet we do want to dial back things like screen time. Now, that's going to take some education, some deep education with the athlete and with the parents too. That's one aspect we want to get done. Maybe Reid can explain how you actually message that to somebody to get it. There's a difference between telling them what to do and getting buy-in, right?
So my big strategy is I bring in as many people as possible. So I'll bring their parents in. You already said it, but it's the first thing I do. I don't let the parent kind of stay out in the waiting room. I say, this is a very important discussion we have to have. You guys need to sit down and say at the end of the night, there is no screen time. We are going to limit especially when your brain's already fatigued, your body's fatigued. You can't be adding that extra stimuli in before you're going to go to bed when you're going to get that recovery time. So bringing the parent in is step one and among the most important, to work as a team. I'll even call over to a nursing office at the high school and say, relative rest is, of course, do as much as you can without bringing on symptoms and keep your body active. But at some point, some of those ADLs are too much. So saying to that nurse, hey, can we have some flexibility on giving this patient some time in case they're really having a tougher time with headaches and dizziness coming on, so they can go down to the nursing office in a quiet environment and just get some time to relax. So being part of the treatment team doesn't just mean us, the parents. It might mean their coach that you give a call to or shoot an email to. It might mean their nurse that you give a call to and shoot an email to. So bringing in other people is my biggest strategy.
I think that's big, Reid. I think that's big. Speaking of bringing in other people, we'll touch a little bit about the way you're approaching maybe the stages of treatment, but what might you see when you're actually looking to other disciplines or back to the PCC, any sort of yellow or red flags that you're identifying throughout the rehab process?
What are you looking for, like yellow or red flags for lack of progression, or where's?
Yeah, that's a perfect example one, right? Because if we see the take home for when they should see us, right? Like if somebody still has symptoms, let's say at 10 days, we're talking dizziness, headache, neck pain, then cervicovestibular rehab is going to be indicated in some days, right? If we want like our elevator pitch to tell friends, family, PCPs, it's like get them there early if they have these symptoms. And yet, as we start to go through the progressions, what might be an indication that it's like, I need to pull in other disciplines to this treatment?
Yeah. You know, it's funny looking at some of those emotional changes in these athletes, looking at some of the affect. That's actually one thing I've found been really helpful in identifying, you know, this is time to bring the PCP back in. Of course, you're looking for time frames of, are we getting improvement? You know, I always look at every treatment in terms of like 2 week sessions of, if in this 2 weeks we have not improved, you got to go back and we got to figure out what's going to help the most. But also you're looking visit to visit. Are you seeing some sort of emotional decline? Are you seeing some sort of, you know, even like cognitive decline? If so, one, immediately refer back to the PCP or talk to the PCP about bringing in some like cognitive behavioral therapy, or bringing in, you know, and I know that we could dive into a whole conversation on referral to mental health specialists, but that's a big piece for people who are not progressing with this kind of diagnosis.
Completely. I appreciate that. I think you nailed the big, right? Cognitive, psychological difficulty. I mean, you know, any worsening or not, you know, unresolving dizziness, balance disturbances, vestibular signs, cervicogenic stuff going on, migraine. Like, yeah, this is something we're not, you know, we can't be stubborn and try to go it alone. You might need to, of course, start with the PCP as their quarterback. And there might be a neuro, you know, or specialist involved in their care, right? Would you like to touch on, you know, for the PTs watching, you know, what does a basic progression look like for the athletes you see? And by the way, it's worth shouting out, not only are you a hockey player, but you're in a cool little clinic where you look out the window of your clinic and you can see the ice, and you take hockey players out on the ice. So this is not something that is, you know, a reach for you day to day in the clinic, is it?
It is not. I'm very fortunate, and not very often do you get to say that I get paid to put some hockey skates on and go skate around with an athlete, which is pretty nice. But you know, looking at what that treatment looks like for us for progression purposes, you know, we're starting off on day 3, right after that 48-hour period, testing them on their aerobic capacity, checking their ocular motor skills, checking their balance, you know, going over movements that are really difficult for them, and trying to do some sort of habituation exercises to make those better. That being, for example, they have trouble getting up out of bed, they get dizzy, you know, working on those movement patterns, and then also working the cervical thoracic, like exercises, those motor control exercises, the neuromuscular rehab, to get better control of that area. And all the research points towards you need to address those 5 areas to actually fully treat this kind of patient. You can't really just pick and choose and go after one thing. So starting with the basics, I mean, it might be as simple as, can you sit on the bike on minimal to no resistance and pedal for 30 seconds without symptoms increasing? And it might be that simple. That's why it's so important to start early and to go often. Honestly, with something like this, you know, we're trying to get them back to sport, and with neurological based treatment, often it's easier just to go 4 days a week, potentially, you know, see them at a much higher volume, but for a much shorter period of time, which actually significantly decreases their length of stay. But yeah, starting with those very basic aerobic oculomotor exercises literally might just be simple follows of a dot for ocular motor exercises. Balance training might even just being able to stand with 2 feet close to each other, doing a tandem or a semi-tandem. But yeah, starting really simple. And then obviously that progresses through the next phase. But in that first phase of treatment with us, which is really their second phase of what it looks like going through a concussion, it starts very simple.
How often are you seeing the need to address the cervical spine? And I've got to give a little shout out to one of our local colleagues, Paul Iellucci, PT, PhD, is the chair of the up-and-coming Johnson & Wales University program, and this is a real clinical interest of his. And he recently published a study that maybe a lot of local clinicians in the Rhode Island and Mass area contributed to, where they took everyone who was referred for concussion and they assessed the cervical spine. And I expected there to be a lot of cervical involvement, and it was huge. I mean, I'm paraphrasing, but I mean, it was upwards of like 70 to 90% of people referred from their physician with concussion had cervical or upper cervical spine issues, right? Tenderness, limitations, things like that. And these were not acknowledged on the referral. It was just referred as a concussion. Are you seeing it at that frequently? And how do you suggest people dive in and integrate that?
Yeah, it's crazy. I would honestly say I haven't really had a patient who's sustained a concussion who hasn't had some sort of cervical involvement. It's something that, easy enough to screen for. Take them through some active range of motion screening, and see what it looks like versus some passive range of motion screening, and at least you can get an idea of, is there some sort of limitation here? It takes 2 seconds to do. And in some way, shape, or form, all of them have something that you can address, whether it's directly reproducing or contributing to their headaches, which in a lot of cases it is. The upper cervical spine musculature, suboccipitals, everything can get really irritable, tight, tensed, and that goes along with some of that anxiety of having the concussion too. So, what is it actually coming from? Not exactly sure, but I don't think I've seen a single case that I haven't had to address it yet.
That's great. And yeah, identifying it early, explaining to them the why, like, we need to address this. And like you said, it's something you can address early when maybe they're not ready to ramp up, with the aerobic conditioning, right? The aerobic challenges. So what does the late stage look like, right? I can even, in clinical practice, sometimes, like you said, once we get comfortable with the triaging, the treatment, identifying the symptoms, screening them, that can be an okay baseline. Those early stages, it's a little bit like somebody post-op, right? Like they're irritable, they're sensitive, and yet there's only so much you can do. And then all of a sudden you get to a place where you got to break out the creativity a little, you got to ramp things up. So how much does that almost vary, right? You're monitoring the symptoms, and yet I imagine people want to go 0 to 60 or even 0 to 100 once their symptoms start to resolve. And on the other end, I bet you get those people where it's like, man, I really wish symptoms would have resolved in this case, and yet they really linger for some people. And how do you manage that?
Yeah, so it's hard. It's the classic answer in PT school. It depends, and it's a tough one. But I think that you're always looking to progress these patients as quickly as possible. You're pushing the boundaries for what they can accomplish within their symptom tolerance, and moving towards, for each patient, specific activities they have to do. So hockey player, as soon as they're getting to the point where they can tolerate some ocular motor stuff, simple, get a golf ball and get a hockey stick, have them starting to follow the golf ball while they stick handle. Something like that really pushes them towards what they need to be able to do for that patient is the best. You pick that for the hockey player. For the football player, it might be working on literally catching a football with one hand and being able to throw it back and forth, which seems like such a simple activity for a higher level athlete. But that following of the ball that has to come with that receiver catching it and looking it down into their hand, that's where you drop into the more sport specific training. Now, for the patient you were talking about who, isn't progressing necessarily as well as you hope, you have to almost take a step back and say, am I missing something? Where are we? Is there another piece of this component to this? I think that's where I meet that kind of yellow flag that we were talking about earlier of, are we seeing any sort of decline or lack of progress here? Is there another body I can bring into this? Is there, a headache specialist that we can talk about, whether it's some sort of injections, which they found have been pretty effective, Botox injections, et cetera. Is that going to be something that contributes? Of course, that's someone who's definitely struggling after you put a lot of effort into other things. But I like to think about that earlier because, of course, you should always be looking to see, are we actually progressing here? Patients will always tell you, I feel a little bit better, because they want to please us. But you don't want that to deter actually getting to them to a place that may help them out and get them that much faster, obviously. And I think as a primary care practitioner of orthopedic conditions, I think it's so important for us to be ready and willing to get those other pieces of the pie and refer that patient to that other place that's going to provide some of that support and help.
think that's a really great way to put it, Reid. As primary cares of orthopedic conditions, you're the one who, in many cases is going to be seeing this person more than anyone else and quarterbacking their care a little bit. And Jimmy, by the way, how did you pull up that Paul's article so quickly there? I didn't tell you I was going to mention that.
We call it Google. You open a new tab and you Google it. That's
impressed. That was quick.
Fast Google hands.
Yeah. Reid, but at least last question from my end, right? If we've gone through sort of the primary plan of care, what does a last visit look like, right? I think we all have a feel as PTs. We have a feel for like that last visit with my total knee patient, right? Like my athlete who, it can do their throwing program for a shoulder injury. But how do those things intersect? Is it the same? Is it a bit different if you're dealing with somebody who maybe has seen you for a bit for a concussion, is ready to get back to their sport?
Yeah, I think that visit might look a little different. Of course, you're going to go through, reproductive tests that you'd expect that are very sport specific to whatever their sport is, and run them through the paces, as you say. But that last visit might include getting information of the athletic trainer and talking to them about the concussion testing and passing that concussion testing. You never know. The last visit might not be a last visit if you're kind of saying, this is pretty much our last visit, but we're going to kind of check in as you're going into that full practice mode, unrestricted contact, and I'll see you again, even though I feel like you're good and we can get you back in and you'll be kind of released to play. But, you set something up to kind of check in as you go. I think the last visit's kind of more flexible in the way that you're going to be talking to the other providers who are involved. You're going to be maybe even following up with them after their first games back in. So yeah, it's a little different from that standpoint because you never know how that transition to actually contact in sports is going to go. So trying to dot the T's or dot the I's and cross the T's by contacting everybody who you've been involved with throughout the process is the big piece in that last appointment, and taking the time to make a phone call over to an athletic trainer, shoot an email over to the athletic trainer while you're in that appointment with the patient is just as important as giving them some other tools to continue when they're done.
Completely. I think that was a kind of a really good segue. I was going to ask you what your key take home to a PT watching this right now before we maybe jump in if there's a question or two, but you kind of made me think of mine, right? I try to think big picture, how we can make a huge impact on PTs. And you sort of nailed it there when you said, we're contacting different people. You might be reaching out to the athletic trainer, right? You may be the first person to tell a friend, family, patient that we treat this. And when you think about our role as PTs in population health, or if that feels too big and too grand, just think of it as community health. Think of it as the community you practice in. And you can not only raise awareness of it, you can be coordinating with local coaches or athletic trainers or athletic directors and getting into those schools. Show them what a good neuromuscular warm-up or program looks like, and see more of those patients you really like, which, by the way, is a lot of the reason we do meetings and presentations like this, is to share these kinds of things with our colleagues and treat what we love. So my take home would be, own our role in treating this condition and all musculoskeletal conditions. And that includes, being that voice to the community around you, your patient in front of you, their family, but also coaches, athletic trainers, and anybody else that might be involved in these athletes and these athletes' care. What would you tell people to take home from this, Reid?
Yeah, I couldn't agree more with the sentiment of, PTs often get into the zone of, I need to treat this patient, get their note, make sure I give good treatment. But there's a lot more that goes to just the in treatment time. Take the time to talk to the people in your community. I think invaluable resources, the athletic trainers at the schools were around, the coaches who are involved in these programs, and they're the ones who are going to also appreciate the work you're doing and who will be willing to send a kid to you because they know they're going to get top-notch care. So see more of the patients you want because you get involved in care for the patients you have is pretty much how it goes. That's probably the biggest takeaway is from working with this kind of population.
That's a really good takeaway. Jimmy, what do we got from the crew?
We're going to call this section of the show, it's called Aha! ask, high bar, anything. You're welcome. Just came up with that. I don't want to brag, but that deserves a raise. All right. Brian from YouTube asked this question. You mentioned in terms of what does the end of concussion care look like? He asked, what are long-term effects that athletes post-concussion should be on the lookout for? What do you give them and say, hey, if this pops up, you should come back or you should see your PCP? So what's their take home to maybe come back or be on the lookout for?
I'd say biggest things to look out for are the onsets of the dizziness, the headaches, the nausea, the excessive fatigue. Often that's one of the biggest signs that, lasts after concussion is, that mental fatigue, that mental fog. And it's not as easy to identify as a symptom. Like a headache is easy. I have headaches. Is that from my concussion? I have fatigue. It could be from a lot of things in my life, but that excessive malaise, fatigue, the brain fogginess that is associated with concussion and post-concussion syndrome, that things to look out for, telling that maybe, you're pushing things a little too hard. Maybe you need to start thinking about going back in and working some of the things that we've been working on. What do you think, Dave?
Yeah, I think you nailed it, Reid. And thanks for the question, Brian. The only thing I'd add is, if you're in front of them being able to explain that, then you're doing something right. If this was an ACL patient, they wouldn't say, man, I don't really feel confident in my knee, and yet they were discharged 2 months ago, right? Ideally, your return to sport progression has included just that, a graded progression back to what they can do while monitoring that there's not symptoms or an increase in symptoms. So if you're saying goodbye, hopefully it's goodbye to the symptoms as well, and you're still giving the heads up on as Reid just did, were the symptoms to resurface or were they to have a recurrence? Again, it's not all contact injury, so make them aware, make them, an educated person that can tell their teammates what's going on, but hopefully those symptoms have resolved by the time you're saying goodbye to them.
Perfect. All right. Second question from the interwebs was, who actually clears the athlete to return to play? Is it the PCP? Is it the neurologist? Is it the PT? Scott from LinkedIn is like, who's the green light? Who's the person deciding, or does it depend again? Because if it depends, I'm going to need to know, what does it depend on?
It's unfortunately, and it depends to an extent, we'll know, because we spend so much time with these patients, we'll know who's involved in the care team. Did they come from that PCP? Did that PCP? You should be communicating with them as to what does that return look like? Do you want to clear them from your end from every perspective that you need to? Also corresponding with the athletic trainer, having them retake any concussion testing that they took either through the school or through their organization. So of course, it's almost like we all clear them from our own ends. Make sure that we clear them on all the return to sport, all the stuff they need to accomplish physically. They go to the athletic trainer, get cleared on their testing that they need to be cleared on to pass for the school. They've gone to their PCP to get the thumbs up and okay if they were involved in the whole process. So it's kind of cleared by everybody as a group, I guess is the best way to put it.
Mm-hmm. All right. Dave, you want to weigh in? Did I just step on your toes there?
Just a little, Jimmy, just a little. But I'd only add, Scott, good question. You'll know where your patients are coming in, and that helps to inform you about the best way to exit, right? If this was a significant enough injury that they are coming through their neurologist or orthopedist who specializes in concussions, then when's that next follow-up, and you need to be confident saying, I get to spend more time with this patient than you do, and I've seen them go through this graded progression. This is where I believe. So you should make their job easy, where they know X, Y, and Z has been completed and they're good to go. On the same end, maybe the local pediatrician down the road who's seeing a bunch of sick kids from 9 to 5 also has a concussion thrown in there. And because they know you, they're at least saying, you know what, go down the road, see your local PT. Maybe they do, or maybe they don't have a follow-up with their primary care, and you are the decision maker in that case, or at least informing the PCP. So communicate with the other providers involved, but be confident doing your job and being able to essentially sign off, even if you're giving, the decision rights to another provider.
All right, last question in AHA, which is Ask Highbar Anything. Again, just came up with that on the fly. What tests do we or should we be giving athletes pre and post concussion? This is Matt on Twitter. This feels a little like a baseline testing, of course. The best time to do baseline testing is before the concussion, and the second best time is, well, you should have seen me before the concussion. So what should we be doing, pre and post concussion, from Matt on Twitter?
I'll just say, yeah, the pre and post baseline testing is a nice to have. There are certain, you might see certain school districts, obviously, they're doing it if you're playing in the NFL, right? But a lot of school districts around us won't have it, or we've seen some pilot it and not follow through. And the access to those programs may not be consistent. So it's a nice to have, but not something we typically have to, or that we can rely on anyway. The evidence would say we're not relying on that. It's not, you got a B+ on your, cognitive testing, so go back. We still have to do our complete exam. I would compare it to imaging in that it doesn't necessarily change our follow through. So I'd say that, and then I'll defer to Reid on the what he does when he sees a patient.
Yeah, so I think that, of course, the pre-testing stuff is nice to have if you have it. If you don't, again, we go based off of what we're seeing from the patients, what they're presenting with symptom-wise, and where their progression has gone. From a PT standpoint, always good to start with some sort of baseline aerobic testing and other things that, and just like any examination, you need to start off with the really good baseline of tests. From all those categories: your aerobic, oculomotor, your balance, your habituation, your cervicothoracic exercise. Do those on the first day, get all that information, use all that vital information to kind of prove at the end that, yeah, they have surpassed all that. So from a PT aspect, of course, our pre-testing is after the concussion's happened. And now we're looking to just prove that they have met all of those goals and criteria we're looking to get to by the time we're done.
Yeah.
Right.
We'll throw in, if we want, a few other notes, the SCAT-5 or SCAT-5, in addition to another functional outcome measure, the best balance error scoring system. If you're taking notes at home, is a nice functional way to look at somebody's overall balance and proprioception.
And I'm not saying we need to do another episode on this, but just initial thoughts. Were you guys watching Monday Night Football last night? Were you watching the games? There were 2 games on, which is very confusing. I had to go back and forth.
A little bit.
We had this horrific injury. They actually, I thought it was good that they were not sharing it on repeat as they normally do. But this Nick Chubb, running back for the Cleveland Browns, never a great sight. But obviously for PTs, we're looking at this because we're all wondering, like, what's going to happen next. So I'll throw it to Reid or Dave, whoever wants to pick this one up. I saw Dave's face right there, which was mine too when I first saw it. What are you thinking if you're finding out this is an athlete you're going to be seeing in the next couple of days? Where's your head go?
I was just going to thank Jimmy for sharing that during the lunch hour as everybody's, wrapping up their dinner here, lunch here. But, you feel for the guy, right? I actually think we've been so locked in on, like, when we talk athletes, a lot of us are thinking of the local high school athletes we're working with. And I think of, obviously, this guy, it's his career and his livelihood and how he supports his family. And even for high school athletes, they, it's their social life. And so,
Sure.
like, I actually just think of, like, the impact on somebody's life initially, but also that we get to then, be with them and walk them back to what they do, back to what they love. And obviously Nick Chubb's a phenomenal athlete, and these days they come back and do ridiculous things that they couldn't have just a little while ago. And then clinically, I just think, man, there's a lot going on there, and Reid will explain exactly what the MRI findings said.
Nail it.
It's going to be an extensive long go for him. Realistically, it's probably an unlucky triad. He's going to be MCL, meniscus, ACL, if he's lucky, just that. Probably more. It's one of those, luckily, modern science in the NFL have progressed their ability to treat this and get athletes back somehow just as fast and strong. But you got to feel for a guy like this. I was happy, Jimmy. I was on the exact same page as you. They didn't show it a million times, and they weren't zoomed in his face the whole time as they're carting him off the field. And it was more of a positive, and all the fans were cheering for him from Pittsburgh, cheering for a Cleveland player getting him off the field. So, at least there's a lot of positivity on the people looking to to try and shed some positive light on this horrible situation.
Yeah, but Twitter, of course, is having conversations because we as PTs or healthcare providers or anybody in sports medicine start thinking, next, what is it, right? And then where's he going? And of course, if you really want to get a depends or some conflicting advice or opinions, that's where you go. You go on Twitter. Yeah. You guys already did your sort of final thoughts, your parting shots. Is there anything you'd want to say to wrap up this inaugural episode of the High Bar Sports Podcast?
I would say, honestly, thank you to Reid for carrying us. And honestly, Reid, began our sports special interest group, which is what this was born out of. For those who don't know, we have special interest groups that bring together like-minded PTs to talk shop just like this, but without Jimmy wearing headphones and doing all the production, but we're still a bunch of people in a room talking about stuff. And it's whether it's OB, pediatrics, vestibular, sports, running, and Reid's been sort of the leader of our sports league. And this is just an extension of that. We tried to sort of elevate that experience and honestly just share it with more people. So Reid was not only the thought leader on the content of this meeting itself, but for our sports special interest group overall. So thanks to Reid, and thank you for the people who jumped on and joined us.
Excellent. Thanks so much for the insight. Reid, you want to wrap it up?
Yeah, thank you, Jimmy, for making this possible. We do what we do because we love it, and it's nice to be able to get to share the stuff we love. And maybe this means we get more of the patients we love to work with. So thank you for making this possible. It's fun to get out there and kind of talk shop a little bit. So Thanks for a fun day, guys. Smart,
passionate people talking about what they're smart and passionate about. To find out more, check out our website, highbarhealth.com, or also on all these socials at High Bar Health. Thanks so much. Appreciate it.